Hello, everyone. Welcome to this awesome special edition live stream. That's a collaboration between IOCDF and 2020 Mom, and especially a nice extra warm welcome to our new friends from the Blue Dot Project who might be joining us today. The stream is being simulcast on both the IOCDF's platforms and the Blue Dot Project's platforms. And we are here because it is Maternal Mental Health Awareness Week, and we are so excited to be talking about this important topic of perinatal OCD. So I'm just going to give folks a few moments to sign on and to join us. If you're already here, please feel free to let us know in the chat where you're tuning in from, and then we'll get started in just a couple minutes. But yeah, so we've got Cindy, we've got Liz. No matter which community you're joining us from, you know one or both of these people and how awesome they are. So we're so excited to be talking. My name is Stephanie. I'm the program director at the IOCDF, and I'm super honored and humbled to be here moderating this. So, but yeah, so Cindy, you're joining us from Arizona, correct?
I am.
How's the weather down there? Yeah.
It's still mild for us Arizonans, so it's like in the 90s right now, but you know, for everyone else it's hot, but like hot for us can get up to 115, 120. It's where we just stay inside and enjoy the air conditioning.
Don't they always say it's a dry heat about Arizona? Isn't that the thing? Yeah.
And I know some places, I don't know where you are, if it's still chilly or...
Yeah, well, I'm in Boston, so we actually have a beautiful day today up in the Northeast. But Liz is also a nice Southerner down there. She's in Texas and Houston. So how's it down there for you?
Yeah. Hot and humid already, but same as Cindy. We'll kind of take it. You know, 80s and 90s is welcome. When it gets to the hundreds, we start retreating inside or into a pool.
Exactly.
I cannot imagine.
All is good. Yeah. It gets hot in Boston too, though. You know,
it does.
So yeah.
It does. But in the way you're saying, we have our AC, and it's usually we don't have a dry heat up here. It's humid, just like it sounds like in Texas. So we just do the best we can. My bar is much lower. I would say once it's north of 80, that's when I'm wanting to not leave the AC. Yeah.
Yeah, and I'm the opposite, where I would like rather the heat than the cold. So
there we go. There we go. Yeah.
Take it.
Let's see. So we have Hi Beth in Washington County, Pennsylvania, Marissa outside of Philadelphia, Turtle Dove that's a beautiful name, by the way, in Santa Cruz. Great. So welcome all of you. And again, please feel free to keep letting us know where you're tuning in from. We've got coast to coast, it seems like, between Boston, California, Texas, Arizona, Pennsylvania. Great. All right. Well, why don't we get started? Why don't I start getting our housekeeping stuff out of the way? Oh, and hi, Jessica from Seattle. Great. We got the Pacific Northwest in the house. All right. So for those of you who have joined us on one of our many live streams before, you know the drill, but then I'm just going to say a couple things for those of you who may be new. So this live stream is educational and it's not intended to replace therapy. If you have treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find help to locate a trained clinician near you. We are not a crisis hotline, so if you are in crisis or are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the Suicide Prevention Lifeline at 800-273-8255. And then finally, we want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. And just remember that this is being recorded and broadcast out to several social media platforms across several organizations. So just remember that the things that you say, they're going to be there for others to see in the future. So great. So with that, let's dive in and get started. Oh, we had a couple more folks chime in. We have Kathleen in Connecticut, Lola in Florida, Michelle in Wyoming, Chris in County of Sonoma. I'm assuming that's California. I could be wrong. And then Shanna, I apologize, in Virginia. Awesome. A lot of states represented. So we are here today, again, because it is Maternal Mental Health Awareness Week. So we wanted to take this opportunity to talk about perinatal OCD and highlight kind of some of the amazing work that the IOCDF and 2020 Mom have been doing in this area. We have a whole task force we're going to tell you about, a whole resource center we'll get to. But first, I want to introduce these awesome panelists who are here with us today to talk about all these great things. So first, I'm going to introduce Cindy. So hi, Cindy. Cindy is coming to us from the 2020 Mom Organization. She is a mom, teacher, musician, researcher, entrepreneur, and maternal mental health advocate. She serves as 2020 Mom's nonprofit and medical partner lead. And she also runs maternal suicide awareness campaigns and why we're all here today, Maternal Mental Health Week awareness campaign. That is under 2020 Mom's awareness brand, the Blue Dot Project. And again, welcome to all our Blue Dot Project guests who are joining us here today. Her own experience with severe maternal mental health disorder in 2012 sparked her desire to bring change to the maternal mental health care system, as well as work towards mainstreaming the discussion about maternal mental health. So hi, Cindy, and thanks for joining us.
Thank you for having me, Stephanie.
Of course. And next, we have Dr. Liz Mackinville. Again, for those of you who are more familiar with the IOCDF, she almost needs no introduction, but I'm going to give her one anyway. She is the director of the McLean OCD Institute at Houston and on faculty at Harvard Medical School in the Department of Psychiatry. Elizabeth founded the Peace of Mind Foundation, which is now a part of the IOCDF, and helps run OCDchallenge.org, which is a self-help website for OCD. Liz was the first ever national spokesperson for the IOCDF, where she now serves as a board member. She was diagnosed at 12 with OCD and engaged in inpatient and outpatient therapy. Liz engages in clinical work, research, and advocacy with the goal of improving access to care and OCD treatment to make a difference in the lives of those with OCD. So welcome, Liz. We're so happy to have you on this side of the stream. Yeah.
Yes, I'm excited to be here. Thank you, Stephanie. And just really excited about this stream. I think this is such an important topic that we see both clinically and for those of us who live with OCD that we also deal with personally. So I'm excited to be here and hopeful that I can share some insight or helpful support.
Great. Yeah, well, that's actually going to be my first question for you guys is what kind of brings you to this topic? What brings you to perinatal OCD and what makes you willing to talk about it on this kind of grand stage? And Cindy, I'll start with you. Yeah.
Well, I, as Stephanie knows, kind of fell into it by accident. And it's been a really just a serendipitous thing for me, both personally and professionally, where I started working on the task force that 2020 Mom is collaborating with and IOCDF over the past 2 years. And through my work there and learning more about OCD, coming to the realization that I actually had perinatal OCD, both during my pregnancy and during my postpartum period. And so, it's kind of like a light bulb went off between just these great minds that, the leading researchers in this field and being able to hear some of that. It's been a privilege to also channel that personally for me for the work that I still need to do. Now realizing that I'm somebody with lived experience.
Mm-hmm. Okay, thank you. And Liz, what about you?
I think it comes for me from both a professional and personal standpoint. Professionally, I've worked with a lot of patients in the perinatal period who are dealing with OCD, who are seeking support, who often feel alone, confused, scared by these thoughts, kind of you name it. And really, so it's been an interest of mine clinically for a long time. And then, of course, I now have a 1-year-old and have started to tell people that I'm expecting again. And so I'm in the perinatal period myself right now. And, I think personally, there's just been a lot that I've seen it from a professional standpoint and I understand that, but then when you also live with OCD and you see the differences and the way the perinatal period might impact your anxiety or OCD and how you deal with it, I think it's just made it even more of an important topic for me and a passion area.
Okay. Thank you. All right. So I think probably the first question we should address is just broadly, what is perinatal OCD? Because I think people who come from the OCD world, they know what OCD is. People who come from the maternal mental health world know what, maternal mental health disorders are. But we know that perinatal OCD is really not commonly talked about within the maternal mental health field. So I always think it's good to kind of just start there. So I guess, Liz, would you like to give us kind of the broad overview of perinatal OCD?
Yeah, so, I think previously we really coined postpartum OCD and we talked a lot about the postpartum OCD period, but what we found is that we really needed to encompass the entire perinatal period, which starts, as we know, pregnancy and beyond. So after delivery, labor delivery, and after as well. And so when we think about perinatal OCD, it is not, I want to be clear that it doesn't mean necessarily that it isn't OCD, right? It still falls within the OCD umbrella, but it's really like, do we see OCD onset differently? Do we see symptoms increase or decrease, or do we see new OCD, right? So oftentimes, some of the statistics I've seen previously have been that 20% of adults diagnosed with OCD are diagnosed in the perinatal period. And that's a really high number, right? So we're talking about lots of individuals who may have had some anxiety, some OCD symptoms, but might not meet diagnostic criteria until they enter into the perinatal period. And so it could be that OCD onsets for the first time during this period, or it could be that symptoms are increased, or we see a different types of symptoms start to onset. The great news is that treatment doesn't really change. It does a little bit, right? Of course, we're treating the individual. We're going to treat them differently in the perinatal period, specifically medication and different things than we would outside of the perinatal period. But in general, treatment is still very successful, and we can absolutely help get people to a point of being able to stabilize their symptoms. What's really important is that we're talking openly about it. I think previously there was so much knowledge around like anxiety, postpartum depression, and postpartum psychosis, but not a lot around OCD. And a lot of individuals who start having some of the unwanted or taboo OCD thoughts, harming their child, some of these sexual intrusive thoughts that might come on, it often can be misdiagnosed. If a perinatal specialist doesn't understand OCD, it could be misdiagnosed as psychosis or something else, which could be really detrimental, not just to the patient, but to their treatment outcomes. And so we really want individuals to understand, what does it look like if we're seeing OCD during the perinatal period?
Mm-hmm. Yeah, and I think one thing, a couple things I just want to highlight. I love that you brought up the whole time period, Liz, because yes, we did sort of start in postpartum OCD, but as we've done more research and kind of consolidated the research, we do know that it's the whole perinatal period, from pregnancy to giving birth to beyond. And the other thing I think is also important to highlight, although it might seem a little funny because we are in Maternal Mental Health Awareness Week and we are working with an organization called 2020 Mom. It does impact parents of any gender, whether or not you are the childbearing parent. And I always think that's really important because there's been some fascinating research about fathers or, adoptive parents. And so I always want to make sure to call that out. Yep. But yeah, so Cindy, so as someone who, I was wondering if you wouldn't mind sharing a little bit about what your experience was like with perinatal OCD to kind of illustrate some of the things that Liz was mentioning.
Yeah, absolutely. To piggyback on what Liz was saying, my OCD kicked in during pregnancy. And again, being someone as she said, there's a lot of information surrounding depression and, more recently these years about anxiety. OCD was not even on my radar. And as somebody who came into pregnancy with mental illness since my 20s, I thought I knew what OCD looked like. But I think, again, to piggyback on what Liz is saying, the time period of the perinatal period, I think there presents some unique situations where it can kind of muddy the waters a little bit of what OCD, like I think we may have a conception of what OCD looks like, and it may look really different just because you are in a different time, in a completely new phase of your life, whether you're pregnant or a new parent, that I think it makes it tricky. And so for me, I think the first really scary intrusive thought that I had was when I was pregnant. And it was one that I actually have not heard a whole lot about until, I started digging into it. And I had thought for years that I had suicidal ideations, like that, I was having thoughts about suicide, but realizing through the work with IOCDF and this amazing task force, I realized now that, there were intrusive thoughts about suicide. And again, there's a big question of what's the difference between an intrusive thought about suicide and suicidal ideation. And I think I've heard from many clinicians now is that I didn't want to die, but I kept having these thoughts of what if I committed suicide? What if, I'm pregnant, and what if this happened and, hurt my baby? And, I was in a very vulnerable phase already and so many changes. And so that was my first sort of brush with a really severe intrusive thought. And, I think, and Liz can maybe talk more about this, the difference between just intrusive thoughts and full-blown OCD. And I think the tipping point is where it kind of takes over your life and it really disrupts things. And that's where I was, where this thought scared me so badly that I was doing all these sort of coping, really unhealthy coping things, like leaving the TV on or the radio on every day, all day when I was alone, just so I didn't hear my thoughts. You know, any silence would scare the heck out of me, because then these thoughts might come back. And then if they come back thinking that they were suicidal ideations, what if I kill myself when I didn't want to die? But it was the what if I did that. And so that was really my first brush with it. And my son is turning 10 this year. And so, you know, it took me this long to even come to the realization that this was an intrusive thought, you know, and it was very different, looked very different from being suicidal. But at that point, I didn't know. And so, you know, now I'm very determined to, you know, really help spread this, because I've gotten feedback that, you know, I think other parents, other moms have had this. And I believe in the OCD world that actually the self-harm intrusive thoughts is actually common, I believe. So.
Yeah, absolutely. Yeah, thank you for sharing. I think so. If we were to say, you know, generally, especially for folks who may be new to OCD, there's different sort of flavors that OCD can have. We call them subtypes, is maybe the more clinical jargony term, but sort of themes around which your intrusive thoughts tend to focus. I think one of the things that helps distinguish, that might not be the right word, but it helps maybe to think about perinatal OCD versus garden variety OCD, is that they do tend to focus on the baby or the fetus. So it's, you know, in the way you were saying, Cindy, the thought was, you know, I am pregnant, I'm carrying this baby. What if I kill myself and I have this baby? So it, you know, that's kind of how, just to sort of close the loop on that, that's where a lot of the perinatal OCD, one of the clinical features or the hallmarks of it, is that does tend to be, not always, because again, there's, you know, as many different types and subtypes of OCD and perinatal OCD as there are, you know, snowflakes in this world. So there's just, it's never the same twice. It never really looks the same from person to person. But yeah, so I think and Liz, I don't know if you want to talk more about this too, but some of the common things we hear about when people have intrusive thoughts in perinatal OCD is it tends to focus on harm. Like, I'm afraid I'm going to drop the baby, or I'm going to accidentally drown the baby when I'm giving it a bath. Or if, you know, during the pregnancy period, an example is, what if I fall and, you know, hurt the baby somehow in that way?
Yeah, so definitely, you know, we definitely see that. And we also, you know, one thing I've experienced is, as somebody who lives with OCD, I think I was actually much more prepared in the perinatal period, and still am, for an increase in OCD symptoms. Like I know how to do that. I have a team. What I wasn't as prepared for is the increase in general anxiety. And I think for me, that actually threw me for quite a loop, just because I feel like I had this really good support system and understanding of like how to address intrusive thoughts and how to address, right? Like I'm experiencing still a lot of that, even with my daughter, sexual intrusive thoughts, different things of that nature, but I know how to lean into that. But the general anxiety that also comes along with being a new mom, and the guilt and the family opinions and all these other things, and feeling like I don't have the same capacity to manage that as maybe somebody without OCD or without these other stressors would have, has been interesting for me. So, you know, I think it's important to think about all of the ways anxiety and OCD can impact this period. But yeah, we definitely do see some specific things. So it could be around harm, it could be around sexual intrusive thoughts, and then a lot around contamination, right? And so often these fears of like, am I sanitizing the bottles correctly? What if I'm feeling a little bit under the weather and I touch these items? Have I cross-contaminated? Is the baby going to get sick? Is it going to be my fault, right? All of those things being really common areas.
Yeah, and actually, there's a comment here I want to call out, or question here. Skyla, Michelle Renee at 1219. She asked, so if the OCD symptoms come out during the perinatal period but are not focused on the baby, would it still be considered perinatal OCD, or would it be considered OCD? Well, I think the first answer is either way, it's OCD. It's just, you could almost in a way think of perinatal as a subtype of OCD, and then perinatal has its own subtypes. But yeah, so that's why it's not always, there's no, and I'll let Liz talk more, but I just want to say yes, but I'll let Liz take it.
And there's no different diagnostic code, right? So like when you think about your DSM diagnosis, it's going to be obsessive compulsive disorder. It doesn't differ if it's perinatal, if it's postpartum, if it's somebody's OCD onsets during, their teenage years. What we know in general about OCD is that people are born with OCD. This is really important, right? So having a baby or being in the perinatal period did not cause your OCD. It may have been a trigger for onset, but neurobiologically, you are born with OCD. So you are genetically made up to have OCD. What we don't know is why, for some people, OCD onsets at certain times versus others, right? So for some people, like myself, OCD onset in my early teens, and that's a really common time we see OCD onset. So puberty, adolescence, early teens. We also see OCD onset during big life changes, going off to college, getting a job, going through a divorce, life stressors, which also includes the perinatal period, right? So we know hormones are changing. We know that there's increased anxiety, there's increased stress. So you're put at an additional risk for mental health symptoms during this time. But what we know is that it's still OCD. So we're calling it perinatal OCD because we want to draw particular awareness that there is this group of individuals who experience an increase in symptoms or a new onset of symptoms during this time. But as Stephanie mentioned, it's still OCD. And so whether the OCD symptoms are related to the baby or not, I would still call it perinatal if it's onset during the perinatal period.
Absolutely. Yeah, they just because they tend to most often be about the baby or the feed or the unborn child, that doesn't mean they can only be. So
That's
agree
right.
completely with what Liz said. Okay, good. I'm glad that makes sense, Michelle. And actually, this I think
a little bit, Stephanie.
Oh, sorry.
I'd add to that a little bit. I, as somebody who had the onset during pregnancy, looking back to kind of, tap into what Liz was saying, I definitely have had symptoms and tendencies. I just never realized that they could fall under that umbrella of OCD, and so definitely it was much more pronounced to a point where it interrupted things in my life during pregnancy. But I think, having anxiety and depression before, a lot of my triggers circulated around control, and you don't have as much control, I think, especially when you're a first-time parent, when you're pregnant and all these different changes. It definitely is a huge trigger, but I definitely think that I've had tendencies for that, just didn't know how to label it before I was pregnant. So just to share that.
Yeah, absolutely. And this actually, I think, is a good segue into kind of talking about how we got together, Cindy, how IOCDF in 2020 Mom kind of joined. So the reason we really want to highlight, as Liz was mentioning, bring attention to perinatal OCD is because it's so, I don't even think I would say it's misunderstood. I think it's just not known about, to be honest. I think there's just not really a big awareness of it. And there is a significant impact that can have on people, especially depending on who they're talking to, which we'll get in a little bit into a little bit more later. But so Cindy, what kind of from your perspective, let's talk about kind of how we got together and why we formed this task force. And if you want to talk a little bit about the task force work.
Yeah, I think one of the main driving points, and this is probably very specific, is the confusion between postpartum psychosis or perinatal psychosis and perinatal OCD. One we hear a lot and is we often is associated with tragedies in the news with perinatal psychosis, and there's just a lot of fear around it. And we wanted to make sure that people understood, that with the right training, the moms who are having intrusive thoughts don't get their kids taken away, don't have all of these sort of things that people use to address perinatal psychosis, it's a very fine line, as we've seen in this task force, of understanding how to classify whether something is an intrusive thought or whether someone is in the middle of a psychotic break. How is that? And we talk about ego syntonic and ego dystonic and things like that, and using myself as an example, when I had, the intrusive thoughts about suicide, I knew that I did not want to kill myself, but I did not have that knowledge of what an intrusive thought was. And so one of the thoughts that I had was, oh my gosh, this is psychosis. And I think that is a very common thing when, women have these intrusive thoughts. And because we hear all these scary stories about psychosis, not understanding the difference, a lot of times people will jump to, oh my gosh, this is psychosis. This is And that is just, it's a totally different way to approach it, whether it's someone is having a psychotic break or, waxing and waning during, psychosis, or if it's an intrusive thought, how you approach it is entirely different. And so I think that was one of the main reasons where we started digging deeper into understanding perinatal OCD. And there really wasn't a whole lot out there defining it and kind of understanding what research was out there. And Stephanie, you can probably speak more to this, in that part of the task force was doing a comprehensive lit review, which I'm still amazed when I go through it at how much more we need to do and how many gaps there are. But I think pointing that out and highlighting that is so important as a first step to filling these gaps. Now we know where they are. And so I think for me, and I think for 2020 Mom, it was really important to have a defined construct, or at least the beginning of one, for what does perinatal OCD look like? How's it different from psychosis? And for providers and even for moms or family members who have moms in the perinatal period, how can we help?
Exactly. Yeah, so this task force has been going on for almost 2 years now, I think. And we, in the way Cindy was just outlining, we kind of brought the best from the OCD world and the best from the maternal mental health world and merged them together into this fantastic task force that had 3 subcommittees. So there was the research group, there was the clinical provider awareness training and intervention group, which Liz has been a part of, and then there was the public awareness group that actually put together this resource center that we're going to be telling you all about later. But yeah, we basically just tried to attack this issue from so many different sides. So in the way Cindy was just saying, there's not a lot of research, but let's summarize what we know so we can inform everything that we put together and we talk about to the best of our understanding. And also, so we know what the gaps are. So now we know, okay, this is the next area we're going to focus on or seek some funding for. And when it comes to the clinical provider world, obviously, those of you who are joining us from IOCDF, you know OCD, you know how to treat it. But those in the maternal mental health world, this may be something a little bit new to you guys about learning about ERP. You might not even know what ERP is, and we'll talk about treatment in a second. And in the way Cindy was saying again, the distinction between I'm really worried I am going to harm my baby versus I want to harm my baby, and kind of understanding those different thoughts, because we've heard, as we're talking about the impact of perinatal OCD, that's one of the things that I think breaks our hearts the most, is hearing stories about moms or parents who were brave enough to seek help and maybe disclose to a provider who wasn't trained on perinatal OCD some of the thoughts they've had, and kind of maybe they've had, protective services called on them or some other sort of intervention that was not helpful and not really going to help them or their child at the end of the day. So I think that's also a large reason of why we're here. Liz, was there anything you wanted to add to what we were just mentioning?
I think that's great.
Yeah, great. So I guess then we can maybe kind of use this to springboard, because I realized we did sort of skip the treatment piece when we were talking about what is perinatal OCD. So maybe let's backstep a little bit before we get into the resource center to talk about treatment, especially mindful of folks who may be new to the world of OCD. But so Liz, I'll shoot this back to you, but what do we know about how we treat perinatal OCD?
So let's pop back for a second to diagnosis before we go into treatment, because I think we kind of brushed over it, but I want to make it a little bit more clear. So when we diagnose OCD, one of the things Cindy noted that I think is really important is that oftentimes individuals will talk about having some symptoms throughout their life, right? But when is it a diagnosable condition? And so we diagnose OCD when it's impairing with functioning, it's starting to impair with our ability to do things we previously used to be able to do. And that often is defined as interfering with your daily life of more than an hour per day. But so how do we diagnose OCD? So the 2 big things I want to make sure we understand is that OCD, obsessive compulsive disorder, has 2 main components, right? So the first is obsessions, and these are unwanted intrusive thoughts. This is really important, especially when we're talking about OCD in the perinatal period. This doesn't change. So these are thoughts, as Cindy has mentioned and has shared in her own personal journey, these are unwanted. There's not a desire. We don't want them. They scare us, they terrify us, and we don't like them, right? So they're unwanted thoughts. So whether it's a sexual intrusive thought, a harm intrusive thought, it's not a thought that feels like a fantasy or a thought that feels like, that's something we want or would act on. It's a thought that scares us. It distresses us. It makes us, we want to do anything to get rid of it. We don't like the thought. And so that's what leads individuals to engage in these compulsions, also known as repetitive behaviors or rituals. The rituals are engaged in order to get rid of the distress and anxiety from the thought, right? So we either do the ritual to try to confirm that the thought's not true, that we're safe, something bad didn't happen or isn't going to happen. And what we also find that's really important, especially in the perinatal OCD subtype group or group, is how big of a role avoidance plays, right? So we will start to see family members who have, say, fear of harming their child, avoid bathing their child, avoid pushing their child in a stroller, because what if I accidentally cause harm to them, even though they know they never would, and they're able to say, like, I would never do that. That would terrify me. Like, I should call CPS on myself. There's no history. There's no intent. There's not any concern of whether or not these individuals will act on these behaviors, right? These are unwanted thoughts, and the behaviors they engage in are rituals or avoidance behaviors to make sure or to confirm that they're not going to do something wrong or that something doesn't happen. So that's really important. What are some of the ways we might see it onset? As Stephanie and others have talked about, it could be harm. So what if I harm my child? We could see things really common, right? Where we're going in, making sure the baby's breathing, and then going back out, going back in, checking again to make sure they're breathing, right? But the fear is something has happened, and then the ritual is to check and make sure they're okay or safe. For the harm thoughts, we'll see individuals start to remove all knives, all sharp objects in their house. They'll avoid being around the baby alone because they're afraid that what if they are a danger to them? Avoid pushing them in a stroller on the street because what if they accidentally do something inappropriate, right? So all these different ways that we might see OCD onset. And so that's really, like, when we think about diagnosis, it's unwanted intrusive thoughts followed by repetitive behaviors or a lot of avoidance that is done in an effort to relieve the anxiety and distress from the thought. There is no intent, and there is typically never history, right? So this is not somebody who's harmed their child before, who has a history of harm or violence. It's somebody that, like, the family members are saying, like, they would never do this. And they're saying, like, I would never do this. It terrifies me. But what if? Or, but why do I have these thoughts, right? So it's the doubt and the uncertainty that really drives the person's anxiety. So the treatment is the same treatment that we do for typical OCD. So it's a specific form of cognitive behavioral therapy called exposure with response prevention. Oftentimes the gold standard for OCD treatment is a combination of both medication and ERP or the specific form of CBT. Of course, in the perinatal period, medication can look different, right? So there's some medications that are safer or that aren't. So it's really important that you're working with your psychiatrist to discuss that. And then we start doing active ERP, also known as the specific form of cognitive behavioral therapy. What is ERP? Well, it's kind of exactly what it sounds like. We slowly and systematically expose you to your fears with removing your typical responses, right? So that's what that response prevention is called. Exposure therapy alone is not treatment for OCD, right? So if I have a fear that I'm going to harm my baby, and I'm going to cross-contaminate their room, let's just say that's my fear, and that they're gonna die because they're gonna get a disease from me. If the exposure is to, let's just say, touch the baby's doorknob to the room, that's the first level exposure, is touch the doorknob and go in the room, and that's my exposure. That's great. I've done the exposure. But if after I touch the doorknob, I take a Clorox wipe and I clean the doorknob off, or I wash my hands, or I clean the doorknob with soap, and I don't engage in what we call response prevention, right? So I do the exposure, but I engage in a ritual, I actually reinforce the OCD cycle. So what ERP is we want to teach you to do the exposure and engage in response prevention. So touch the doorknob and not undo it. So not clean it off, not engage in that typical ritual that you used to do to feel better. And we slowly and systematically want to do that in a way that makes sense for you and that you can tolerate in a healthy way. To basically, we're going to reteach our brain. And what we're teaching ourselves is that the more we respond to fear, the bigger fear gets. But if we start not responding to fear, the smaller it gets, and it becomes not a fear. Now, the thing I want to note about ERP that's really important is I have quite a few rules when it comes to ERP, but there's three main ones. Number one, an exposure that you're doing with a patient should always be an exposure you'd be willing to do. So we're not actually doing something that's risky or dangerous, right? If we're talking about a 1-day-old newborn, I'm probably not going to go work at my hospital clinic and come home and not wash my hands before I hold them, right? And so that's something that, like, okay, what is reasonable, right? Does it make sense to change your shirt and wash your hands before you hold it 1 day old, compared to does it make sense to do this excessive washing and showering and whatnot, right? So it should be something that is still safe. We should not be asking them to do something that's risky or that actually puts anyone at harm. Remembering OCD goes way beyond the norm, right? So normal rituals of hand washing and behaviors are not something that we have to avoid with OCD. We can still do those, and it's still a trigger, because OCD isn't going to stop at a 30-second hand wash. It's going to want more. It's not going to feel like it's enough. The second piece is exposure should never be a surprise. So you should never throw a surprise exposure on a patient. It has to be something we agree upon and we're both in agreement, because we don't want to flood them. We don't want to overwhelm someone, especially someone in the perinatal period, right? Our anxiety and distress tolerance is already going to be dysregulated. And so let's not overwhelm and make that super anxiety provoking, right? So and then the third is that as a clinician, you really should be doing it together early on, right? You want to support them. You want this to be collaborative. And so you want it to feel like we're in this together. We're doing this together. You have my support before we ask individuals to go do it on their own. If a patient could do all of this stuff on their own, they wouldn't be showing up to our door. But we slowly and systematically are going to have them start doing exposures with response prevention. And what they're going to see is that, oh, wow, I actually start to feel better and have more insight if I don't give in to OCD, because what they will find is that the more they give in through rituals or checking behaviors or whatever their rituals are, the more they get stuck. Right? So trying to solve OCD is all based on uncertainty, right? I want to be sure the baby's safe. I want to be sure I'm not going to do something wrong. I want to be sure I'm okay. We can't ever be 100% sure. And we have to accept that. And the more we try to be sure, the more stuck we get. So solving gets us stuck. Compulsions make us more confused. If we can remove those, we actually will see an increased amount of insight, and individuals will be able to have their own healthy balance of being a parent.
That was great, Liz. That was super thorough. Thank you for that. I love all those rules, frankly. I feel like we should have them tacked up somewhere. But great. So now that we've kind of talked about what perinatal OCD is and how it's diagnosed and treated, I do also want to point out, so we've been putting, Skyla's been putting some things in the comments from our Perinatal OCD Resource Center, but I did now want to sort of talk about that and how it might be useful to you, no matter who you are watching this today, whether you're someone with a lived experience, a supporter, a clinician, an advocate, or just someone who happened to wander in, and we're so glad you're here no matter who you are. But we just want to tell you a little bit more about our resource center and kind of the great things there for you, both you and the people in your life and your colleagues, et cetera. So Cindy, I don't know if you want to kind of give us a general overview of it.
Of the center, or okay.
Mm-hmm.
Yeah. So actually, I'm going to let you kick that off, Stephanie, since you.
Oh, sure. No, that I'm happy to. Yeah, I can talk all day. Yeah. So we're super excited to, take advantage of it being Maternal Mental Health Awareness Week to kind of launch this into the world and tell you all about it. But basically, we built this resource center as part of as a collaborative work among the task force and its various subcommittees, just to kind of have a one-stop shop for info about perinatal OCD. So if you're someone who thinks you might have had it or actively has it or who lives with it ongoing, we've got information for you about, some tips and tricks about how to work with your care team and things like that. We have, if you're a loved one or supporter, we have some info for you about how best to support the person in your life as well as yourself. If you're a clinician or just a provider of any type, we have info that is kind of relevant to you within your scope of practice. That's one of the new things to us in the IOCDF world, and not new at all to the maternal mental health folks, is all the various health professions that we got to get on board with this. Because of course, as Liz was just explaining, we therapists are on board. Of course, we know exactly what to do if you come to a therapist with your perinatal OCD concerns. The folks who may not yet know what to do, but hopefully will now that we've got these this info launched into the world, are people like your OB. Or your primary care provider, or your child's primary care provider. If you work with a doula or lactation consultant, there's just so many professions that touch the perinatal period that we wanted to make sure we had information that would resonate with them within what they do. Because we're not asking your OB to become the person who treats your perinatal OCD, but they need to know about it so that they're not, calling CPS when you tell them about your intrusive thoughts. So yeah, there's just a lot of really great info on the Resource Center, including things for, there was a question earlier about assessment and screening tools. So there's all that on there. There's information about treatment and then where to seek out training on how to do the treatment. There's places to look for therapists who are trained in working with perinatal OCD. And one of the really cool things that is highlighted in the Resource Center, another group we've partnered with in this work is called Postpartum Support International. Some of you may be familiar with them, especially if you're in the maternal mental health space. But some of the awesome momvacates from our task force are now leading a perinatal OCD specific support group as part of PSI. So all that info and more is found in the Resource Center. So we highly encourage you to take a look and share with whoever in your life it may be most appropriate to share with. And also feel free to give us feedback about it. If you think we missed something, if there's questions you still have that we didn't answer, let us know, because it's a work in progress. Our work is never going to be done in this field. So we're always interested in more about that. But Cindy, was there anything you think I didn't highlight that I should have, or you'd like to?
I think one of, I worked a lot on the provider group. And so one of the most exciting, I think, work products from that was the core competencies that we had listed for providers by category. And as Stephanie had said, there are a lot of touch points, in the perinatal period, whether it's OBs or, maternal field specialists. I mean, there's just so many. And we took the main ones that we thought and we listed, worked with the team to figure out core competencies for each. And I think that is incredibly helpful because it's kind of structured in a way that you can kind of look for your group and see what is relevant to that. And I think there's going to be an infographic coming soon, right? Or if it's out, but there's there's a lot of information there that I think is really great because I think a lot of providers are still, I think there's still a gap between the OCD world and the maternal mental health world, just like ERP, that's very familiar for you guys, but in the maternal mental health world, there's a lot of overlap that we are working on to, work and bridge that gap.
Yeah, absolutely. And so we'll post in the comments, I see a couple folks asking for the website for the Resource Center. We'll post that for you. It's just iocdf.org/perinatal-OCD, but it's not necessarily the easiest to remember, but we'll pop it. There you go. Thank you, Skyla. But so, yeah, and that's again, it's sort of your one-stop shop. So the info for everybody is there. You can just kind of follow the landing page to see which box might be the most applicable for you to click. So yeah, so let's just take a look. We've had a couple, we have Turtle Dove saying it's so validating to have this talked about, agreed, and thank you for being here. Same with Capea, I hope I'm saying that correctly. Thank you for your advocacy. We need to have conversations about this. For Stephanie, who asked if this would be recorded, yes, this will be. This will be available, I think, on both the IOCDF and the Blue Dot Project social medias after. So just come back to us after and it'll be here for you. Oh, and Liz, a question for you. Gabriella asked, solving gets us stuck. What was the other phrase?
Solving gets us stuck. Compulsions make us more confused. So just keep thinking about the fact that the more we go down this OCD rabbit hole, it's harder to get out. And OCD always pulls us in, right? Because one of the ways we understand OCD is it's urgent. It feels really urgent. We have to respond. We have to solve this. Oh my gosh, this is a huge deal, a huge situation. But the second we get pulled into kind of crossing that bridge towards solving or compulsing to try to have a better understanding or better clarity, we actually get more confused and we get more stuck. I also want to answer, there was a question earlier, sorry if we've already answered this, but best assessment tools for providers for OCD and perinatal OCD from Anne. So, we still use very similar assessment tools. So the YBox, like the YBox 2, that's YBOCS-2, is our most, and the YBox 1 even, are our most validated instruments and measurements that we use to assess for OCD. So this is a 10-item measure, 5 questions focused on obsessions, 5 on compulsions. Y-box 1 is at least. It's a pretty simple measure to administer clinically. And so we still use very similar assessment measures and tools, although there may also be some perinatal specific ones that are out there. Marissa at 1126 said, as someone who experienced perinatal OCD, how can I raise awareness? Just like this, I think the more we have brave individuals, Marissa, like yourself and like others who are willing to speak out and just talk about how it impacted them and be able to share education and resources. I love that IOCDF, I love that 2020 Mom and so many others, Blue Dot Project, et cetera, have so many great resources. The more we can share appropriate resources that we know are evidence-based, that are really sound resources that are based or rooted in research, the more we're going to be able to help spread the message and diminish the stigma.
Yeah. Cindy, I don't know, would you have anything to add to that as well? Yeah.
No, I think she hit all of it. It's great.
Yeah, and I do want to also, thank you for asking that, Marissa. That's a great question. I also want to see if we can maybe broaden it to the other folks who may be with us. So would you guys have any thoughts about the best ways for family members or clinicians or providers of any type that they can join this advocacy work? It might just be the same answer, but just curious. Yeah.
From a clinical perspective, I'll just say, I think the more what we've learned over the years in mental health work in general is that the more specialized and focused, the better the outcomes. And so I think it's a disservice if we do OCD work to not understand the way it might specifically impact the individuals experiencing the perinatal period, right? Both moms and dads. And I think that it's important for us to become educated, to understand, and to think about how treatment might look different and have a good list of sound referrals in our back pocket to always be able to give. And I think that's the best thing we can do from a clinician standpoint, but I'll let Cindy share from a personal standpoint as well.
Yeah, I think you guys definitely hit on all the important touch points of that. I was actually looking at, there's a question in there that I think that maybe we'd want to address from Kim Roy Harris about how they talk about a lot of the stress and distress can compound with carrying out a seemingly good parental behavior and belief, and that can morph into something that is OCD. I think that is absolutely true in my case. Beyond the suicidal, the intrusive thoughts about suicide, I think after my son was born, it morphed into something where I was worried about him while he was sleeping. And I think, again, we talked about the tipping point between just an intrusive thought and full-blown OCD. I was checking him so much that I was sleeping only about an hour a night, for a prolonged period, which definitely did not do my mental health any good. And it was something that is very extreme. And I hear this very commonly, and Liz, maybe you can chime in too with your clinical experience, but I hear that very often, that a lot of times the intrusive thoughts and the triggers revolve around the wellness of baby and what a good parent should be doing, but it gets blown out of proportion. So I just wanted to validate that that's definitely true.
Yeah, 100%. So this is really common actually with all subtypes of OCD, where we'll see that often it's rooted in some sort of real life trigger or real life reality, right? Which is that if you I remember when I was first starting to prepare for Olivia's arrival, I didn't know that like sanitizing meant you needed to wash and sanitize. And I didn't understand how often you needed to sanitize versus not. And then feeling triggered of like, am I doing this enough? Am I doing this right? And I saw other moms be able to navigate it without that urgent sense of anxiety of kind of like, oh, it's good enough. Or like, oh yeah, like I threw them in the dishwasher and that's fine. Where for me, it was like throwing them in the dishwasher, but like, are my hands perfectly clean before I grab them? Am I not cross-contaminating? Am I putting them in this place? Is nothing else happening? And so, I think it's really like, it makes total sense that oftentimes it's rooted in something we're being told or something we're hearing, right? The doctor says something to me. This happened with my daughter, Olivia, as well. Hey, we need to be weight checking her because she's losing a little bit of weight and we just need to be on top of it. I hear it as like, oh my gosh, right? And it becomes it's overbearing. I'm not able to be present with her because I'm only focused on her intake and everything that's happening and is she okay? The doctor didn't mean it to that degree, right? They weren't that concerned, but that's where my OCD took it or my anxiety took it. And so 100% this happens all the time. And this is what I was saying earlier of like, sometimes people think, oh, well, so to treat OCD, we have to tell people that basically like they can't they can't sanitize at all. No, like we're not asking them to do something that they shouldn't do, because what we know is that actually OCD treatment of sanitizing normally, or like a functioning sanitizing behavior compared to OCD sanitizing, is still triggering, and that is still treatment, right? During COVID, we didn't tell patients don't wash your hands and go, purposely get exposed. Like that's not what we would recommend, but we did ask them to start following CDC guidelines instead of OCD guidelines.
So there's another question from Shana at 12:43 about any recommendations on specific ERP training for the perinatal period for psychotherapy providers. I'm going to give Skyla a link to post. We actually list out a bunch of these as part of the, when we talk about the core competencies for each profession, we include a bunch of trainings as the way for folks to be able to achieve these core competencies. But I will say that this is something we're still sort of looking into. So the IOCDF, we have a really awesome training institute about how to work with OCD as a mental health professional. And there's, from 100 just getting started up to 400. I've been doing this for years. So we have something for everybody along the way. In terms of specifically in the perinatal period, there are a bunch of trainings that you'll see on that link about working with maternal mental health disorders that touch on OCD, but they don't really get into the specifics of how to work with it as a therapist. So it's a little bit of both. You may have to kind of DIY it a little bit, although watch this space, of course, because we may come up with something in the future. But so if you want to know the nitty gritty of working with OCD and ERP and all the things that Liz talked about earlier, I would definitely suggest taking a look into the IOCDF Training Institute. And then if you're kind of new to the world of maternal mental health, there's a whole bunch of trainings. I think PSI and 2020 Mom do a lot of them that are listed on that page as well. And I will
also say that if you go to IOCDF or YouTube/IOCDF, you go to our YouTube channel, we have done a couple webinars specific on perinatal OCD. So there's those resources as well. But across the board, the Behavioral Therapy Treatment Institute and specific OCD trainings should cover OCD generally, which should be applicable to the perinatal period.
Yeah, absolutely. And I also do want to put in a plug for if you're interested, we will have series on perinatal OCD at both our in-person Annual OCD Conference in Denver and our online OCD conference. So the in-person conference in Denver is July, online conference is in November. So pick one or both. Honestly, I think you should come to both, but that's just my personal bias. But we will have both information and educational sessions for clinicians, for lived experience folks, and we will also have groups for folks who live with and want to kind of connect with others at both the online and in person, with a rotating all-star cast of folks from our task forces. So you'll be learning from the best of the best. Great. Let's see, what other questions do we have here? There was one earlier. Liz, I have a feeling if anyone knows this, it will be you, although this may be something we don't know enough about. But so Missy Hem asked at 12:24, could you speak to the difference between OCD and obsessive compulsive personality disorder and how that might present in the perinatal period?
Yeah, so the big difference between OCD and OCPD is the function of the behaviors, right? And also the way the behaviors impact us. So when you think about OCD, the two things I talked about earlier are that the obsessions are unwanted intrusive thoughts, and the compulsions are behaviors that we engage in because we feel like we have to. The compulsions do not bring us any pleasure, do not bring us any joy, but we do them because we feel like we have to. In fact, even if a compulsion takes someone 30 seconds, you'll hear people with OCD saying that those 30 seconds are grueling, right? They hate having to do it, but they do it because they feel like they have to. They don't enjoy these compulsions. They do them because it feels like it's the ends to this distress. With OCPD, very different, right? So the thoughts with OCPD, the obsessions are typically not unwanted intrusive thoughts. They're thoughts that are bothersome, right? So I don't like the way this looks, or I don't like the way this feels, or this isn't done the right way, this isn't done appropriate. But the thought is not necessarily disturbing or distressing. It's more just rigid, there's a right and a wrong, and this is how something should be. The compulsions for OCPD, such as maybe organizing your closet or whatever, the individuals do talk about how those do bring them some pleasure, that maybe the activity themselves, they don't like having to do it, but afterwards that they find pleasure or enjoyment in the outcome, in the way that the closet looks, or in the way that the organization happened, or the way the kitchen feels after when it's clean. Very different than OCD. And so you would see the same in the perinatal period, right? Somebody who is kind of like rigid in like their systems or the way they want things set up in the baby room or the way things are supposed to go or be laid out. And they'll talk to you a lot. One of the things people with OCPD will say is they'll say things like, it helps me function. It serves a purpose. It's useful to some degree. Individuals with OCD, our behaviors, they're not useful. They don't serve a function. They actually are disruptive. And so they're very different in that aspect.
Great. Thank you. All right, so I'm seeing we have about 6 minutes left. So I'm wondering if maybe we do one more question, and then I want to give you each the chance to leave us with a closing thought, and then we'll do some final announcements. So let's see. So Turtle Dove at 1247 asked, how about trauma and adverse childhood experiences? Can you share on the interplay?
Sure. So we know that individuals with PTSD and trauma diagnosis do have higher rates of OCD. So we've seen prevalence rates of OCD across the general population is about 3% globally. When there's a diagnosis of PTSD, it can range from like 5 to 12%. So we definitely do see an increase. And what we know is that trauma can onset some OCD symptoms, and they can be related. What we also know is that treatment needs to look different. If somebody has a comorbid PTSD and OCD diagnosis, the PTSD needs to be treated first or at the same time, but we certainly don't want to start OCD treatment if we haven't addressed the trauma. The treatment for OCD, leaning into uncertainty, doing the exposures could be re-traumatizing and triggering that wouldn't be useful. So they absolutely could play on one another, and we'd want to do a full thorough assessment to understand what exactly is going on and to be able to treat the whole picture.
Thanks, Liz. All right. Well, so as we're starting to wind down here, I want to give you each a chance to kind of share if you have a final takeaway or a little piece of inspiration or advice or anything you all want to leave our viewers with. Cindy, why don't we start with you?
I just wanted to thank IOCDF for this amazing partnership and this resource that I think and hope will help a lot of moms and providers in the space, myself being one of them. And so I really encourage everybody to take a look at it. And as Steph had said before, hopefully more to come.
Mm-hmm. Absolutely. And Liz, what about you?
I just want to echo, I think that during the perinatal period, there's a lot going on. Your stress, your anxiety, everything increases, and it's expected to a degree. But what we don't expect is the level of disability and the level of interference with our mental health and our stability that OCD can cause. So it's really important for us to take these signs and symptoms seriously and to get people to specialized treatment. What we know is that general mental health treatment is not going to give individuals the relief that they deserve, but specific OCD treatment can. And so if someone, or you're suspecting someone's dealing with perinatal OCD, get them a referral to an OCD specialist so that they can get the help they deserve. I also want to say that it doesn't matter if you're dealing with severe OCD during the perinatal period or another period in your life. Hope and help are available, and with the right treatment, you absolutely can get the relief that you deserve.
Yes. Thank you, Liz. That was going to be, I was going to allow myself a takeaway as well. And that was absolutely going to be mine is if you're watching this, just know that you're not alone. Know that there's people who understand what you're going through. We are here for you, and we're excited to welcome you to our community and get you connected to the help and resources that are out there for you. So let me just do a couple final announcements before we close off for real. So this is just one of our many awesome live stream options, just to give you a heads up about what's coming down the pike. Next week, we have beloved Ethan Smith coming back for community conversations on Tuesday at 7 Eastern. You can ask questions live, like many of you have been doing here, or also submit them to iocdf.org/peaceofmind. And so we did already talk about the conference, but just a reminder that if that was exciting to you, if you want to come see that in-person perinatal OCD series, registration is open. So for the 27th Annual OCD Conference, again, it's in July in Denver. It's for anyone impacted by OCD and related disorders. So including if you live with it, if you're a friend, family supporter, therapist, a provider of another type, researchers, etc. Our conference is just super awesome that the community is so open and inclusive. So we invite you all to learn more and register. And kind of attached to that, for if there's any researchers or folks who are interested in research, our annual IOCDF Research Symposium is also going to be in July, and registration is open for that. So that'll be folks sharing data and findings from their latest research. And it's actually going to be a hybrid event this year. So you can learn more and register for that as well. More imminently, this coming Monday, May 9th, we will be having our Faith and OCD conference. It's for people of faith, faith leaders, and mental health professionals. And then Skylar's going to post the link about that as well. And then finally, we have our 1 Million Steps for OCD walk is coming up. And we invite those of you who have come to many over the years, those of you who may be just hearing about us today, no matter how long you've been involved with us, we welcome you to join us. They're going to be in June and October. They're all over the country. You can either find one near you or create your own. And Skylar will post the link about how you can register for that. It's just a really fun day of community and advocacy, and we invite you to join us for that. So with that, thank you all. This has been a fantastic hour. Thank you to Liz. Thank you to Cindy. Thank you to 2020 Mom. Thank you to the Blue Dot Project. There's still a couple more days of Maternal Mental Health Awareness Week, and this was only one of many things happening. So while we are particularly interested in the perinatal OCD aspect, we invite you to learn more in general and to participate in advocacy in whatever way is the most comfortable to you. So thank you all for being here, and we'll see you next time.
Thanks, everyone.
Thank you.